Welcome to this medicine masterclass on COPD or chronic obstructive pulmonary disease. COPD is characterized by progressive airflow obstruction which has little or no reversibility, as well as an abnormal inflammatory response in the lungs, commonly due to cigarette smoking. The most common respiratory symptoms include chronic and progressive shortness of breath, a chronic cough with sputum production, wheezing and chest tightness, as well as other symptoms such as fatigue, weight loss, anorexia, ankle swelling, and symptoms such as depression and anxiety. Let's take a case, Mr. Williams presenting with shortness of breath, and discuss the common features on a respiratory examination in a patient with COPD. On examination, taking an inspection, palpation, percussion, auscultation approach, from the end of the bed, the patient may appear breathless. They may have pursed lip breathing. They may be using their accessory muscles. You may note tar staining or central cyanosis. The chest may appear barrel-shaped, and you may notice inspiratory retraction of the lower ribs. This is known as Hoover's sign. On palpation, you would note a decreased cricosternal distance with no tracheal deviation and symmetrical chest wall movement. Percussion would result in increased resonance as well as obliteration of the cardiac and hepatic dullness due to the increased AP diameter of the chest. On auscultation, you would expect decreased breath sounds, poor air entry, and increased vocal resonance with an occasional polyphonic wheeze. When you inspect the hands, you're likely to see nicotine staining, clubbing, and some signs of peripheral cyanosis. Examining the face and the neck, you'd expect to see a raised JVP consistent with cor pulmonale or right heart failure. The differentials, apart from COPD, would include other conditions which damage the parenchyma of the lungs. This would include emphysema, in younger patients, conditions such as alpha-1 antitrypsin deficiency, chronic bronchitis, asthma, and bronchiectasis. Putting this together, you'd convey that Mr. Williams is presenting with shortness of breath, comfortable at rest, and I believe the patient has signs consistent with COPD. From the end of the bed, the patient appears breathless with pursed lip breathing using accessory muscles. There's evidence of nicotine staining, central cyanosis, and early clubbing. On inspection of the precordium, I noted a barrel-shaped chest with reduced cricosternal distance and no tracheal deviation or tug, and the chest wall movements were symmetrical. Percussion was hyperresonant, and I could not appreciate the cardiac or hepatic dullness. On auscultation, I noticed decreased breath sounds, as well as poor air entry throughout the lung fields, and increased vocal resonance, and an occasional polyphonic wheeze. The JVP was raised consistent with cor pulmonale, and differentials include COPD, emphysema, and alpha-1 antitrypsin deficiency or chronic bronchitis. To complete my examination, I would like to ascertain a thorough medical history, perform further clinical examinations, and organise a range of investigations. And the examiner may ask you, what investigations would you like? Well, blood tests are very important. An FBC would allow you to determine whether there's an anemia of chronic disease or a reactive polycythemia, whether there's the presence of raised white cells, which could be as a result of infection or steroid usage, Usanese and CRP, alpha-1 antitrypsin deficiency levels, and if the patient's on drugs, drug levels would also help in the management. Blood, clotting, PT and INR can be used as baseline. You can assess for whether the patient has any other conditions such as diabetes by assessing their glucose or HbA1c. And importantly, if they have signs of infection, if they're coming in with decompensation or fever or septic markers, aerobic and anaerobic cultures should be sent, as well as a sputum MCNS. An arterial blood gas should also be performed to assess for signs of hypoxia or hypercapnia, whether the patient has acidosis resulting in respiratory failure. Imaging, a plain chest radiograph would demonstrate hyperinflation, flattened hemidiaphragms, and bullae, and may also demonstrate consolidation if the patient has lobar infection. An ECG may demonstrate right heart strain as a result of cor pulmonale, and an echo would be useful to confirm the diagnosis of right heart failure. How would you manage these patients? It's important to manage such patients holistically with a patient-centered approach involving a multidisciplinary team, recognizing that there are conservative, medical, interventional and surgical options available, and that you would take the guidance of the GOLD guidelines, for example, to help determine the management. Conservatively, it's important to recognize the biopsychosocial impact of this diagnosis, as well as to provide education about this condition. Dietary inputs and supplements if the patient's losing their appetite or becoming anorexic, screen and treat depression, and offer regular annual vaccinations, for example, flu and pneumococcal vaccines. And if required or indicated, pulmonary rehabilitation should be offered. But what's key is smoking cessation is the highest priority. Whether that's pharmacotherapy, nicotine replacement, it's important that this is advocated strongly. Spirometry facilitates the management and is also used to make the diagnosis. In a normal patient, they would have a good FEV1, but in COPD, the FEV1 is reduced. Now, if in the presence of a post-bronchodilator test, the FEV1 to FVC ratio remains reduced less than 0.7, then that would suggest that there's persistent airflow limitation facilitating the diagnosis of COPD. GOLD guidelines, or the Global Initiative for Chronic Obstructive Lung Disease guidelines, categorize patients based on their spirometry as GOLD 1, 2, 3, or 4. In mild, moderate, severe, or very severe airflow restriction based on their FEV1. If the FEV1 is over 80%, they're GOLD 1. If the FEV1 is less than 30% predicted, they're put into category 4. As well as this, patients are asked a series of questions, and there are several potential questionnaires that can be used. Most commonly, we use the COPD assessment test or the Modified Medical Research Council questionnaire, the nMRC. The CAT test asks a number of questions. There are a total of 8 questions, and patients score 0 to 5. A maximum score of 40. The higher the score suggests that the patient is experiencing worse symptoms. The nMRC scale, patients rank themselves as grade 0 to 4 depending on how breathless they feel or how bad their symptoms are. Now, combining the spirometry as well as the questionnaire responses, patients are categorized using the GOLD ABCD tool. Patients in group A and B are those who are GOLD 1 or 2, i.e. they have mild to moderate airway limitation. But what distinguishes A and B is the symptoms. Group A are those patients who experience few symptoms, and B experience many symptoms. Group C and D are those with severe or very severe airflow limitation, i.e. GOLD 3 or 4 category. But the difference between C and D are C are those patients that despite having very severe or severe airflow limitation experience less symptoms, and D are those which experience severe symptoms. By using this assessment tools, this then facilitates the therapy. So if the patient is Group A, you can offer bronchodilator therapy. Group B patients can be offered a long-acting bronchodilator, either a LABA or a LAMA, and Group C can be offered a long-acting muscarinic antagonist, and a patient who is Group D may require more aggressive therapy such as a LAMA or a LAMA plus a LABA or an ICS and a LABA. So there's a number of drugs available, including the LAMAs and LABAs that we mentioned. Some patients may require steroids, particularly those that are steroid responses. For infections, they may require antibiotics, and long-term may require mucolytics. There are many agents that are available. In terms of beta agonists, there are short-acting beta agonists and long-acting beta agonists. Anticholinergics also, there are short-acting and long-acting. Examples of short-acting beta agonists would include salbutamol, terbutaline, and long-acting beta agonists would include formoterol or salmeterol. The short-acting muscarinics include ipratropium bromide, and the long-acting muscarinics include glycopyrronium or tiotropium. There are combinations of SABAs and SAMAs. This would include, for example, a salbutamol and ipratropium combination, and there are a combination of long-acting beta agonists or anticholinergics, such as formoterol and aclinidium. Other agents available to manage COPD include mesalvanthines, such as aminophylline or theophylline, as well as phosphodiesterase 4 inhibitors and mucolytic agents such as carbocysteine. GOLD guidance advocate regular reviews to either escalate, switch, or de-escalate therapy. Patients should be reviewed for their symptoms, for their degree of dyspnea, the frequency of exacerbations. They should be assessed in terms of their inhaler techniques and their adherence, as well as any non-pharmacological approaches such as pulmonary rehabilitation, and whether the educational approach is also facilitating them. By taking these, the patient's therapy should be adjusted, either escalated, switched, or if the patient's making improvements, de-escalated. Offer pulmonary rehabilitation. This is structured and supervised exercise-based training in conjunction with smoking cessation, nutrition counselling, and self-management and education to help patients live and cope with their COPD. In some patients who are chronically hypoxemic, they will require long-term oxygen therapy. An nMRC trial showed that if the partial pressure of oxygen is maintained more than 8 kilopascals for 15 hours a day, then survival significantly improves. LTOT is a result of a multidisciplinary team meeting along with the patient to decide whether this is a suitable therapy. And this should be given to clinically stable non-smokers. Of course, you can't smoke with the presence of oxygen, that's a fire risk. So clinically stable non-smokers with a PO2 of less than 7.3 despite maximal treatment. And that PO2 should be measured on 2 occasions at least 3 weeks apart when the patient is stable. Or if the patient has a PO2 of 7.3 to 8 but has pulmonary hypertension, cor pulmonale, then they should be offered long-term oxygen therapy. This is also an option for terminally ill patients as well. If the patient has type 2 or type 1 respiratory failure, then they may require non-invasive ventilation through a tightly fitting face mask and an NIV machine. Type 1 respiratory failure patients will require CPAP, and type 2 respiratory failure patients who are hypoxemic and hypercapnic will require BiPAP. In patients who have developed excessive bully and require lung volume reduction, they could be offered a bulectomy or lung volume reduction surgery or a lung transplantation. Thank you for attending this medicine masterclass.